Session 15 is about orders that primary care doctors handle all day and every day. We dig into our processes and logistics for labs and imaging and highlight how physicians think about costs related to these elements. We also discuss our experience with ordering durable medical equipment.
In the last session, we talked about medicines. This session, we're going to talk about every other type of order, starting with labs. The logistics of labs begins with where the labs are drawn. And there's really three major options: in the office or the point of care where the labs are ordered, at the lab site of the lab company, or at home. There are two possibilities for in-office labs. The more common one is where the office is mainly a lab draw site. The specimens are prepared but not processed and then sent to the lab to be processed. In this kind of setup, which is most traditional primary care setups, the lab company will actually provide most of the resources. That involves the tubes, the needles, the centrifuge, any gauze, the tourniquet. And if the volume is high enough, which for most traditional primary care practices it is, the lab company will actually provide a phlebotomist to sit in the primary care office and draw blood all day. Other places like hospital systems will have their own phlebotomists, but usually the material is still provided from the lab company. And then after the labs are drawn, usually daily or some higher volume places, twice a day, a courier from the lab company will come to the practice and pick up all the labs to bring back to the lab company for processing. In some settings like urgent care and, of course, emergency rooms, there are in-house labs where a lot of the basic lab orders can be processed on machines that the practice itself owns. You generally don't see this anymore in fee-for-service primary care clinics because these machines are incredibly expensive, require a lot of upkeep, and there's a lot of regulation to even have the machines around. The next location, being the lab site itself, really looks like an office visit. A lot of them are walk-in, where you just show up to the draw site or make an appointment to the draw site, show up, they take your registration, check the lab order, you sit in the waiting room, they call you back, draw your blood, and then you go home. The final location is at-home lab draws. This is a little bit newer. There are companies like Dispatch Health, which will come out and draw your blood. Pretty simple process, but most primary care doctors aren't engaging these services. A lot of the companies that do it are really like urgent care on wheels, where they'll come in, do the full assessment, and then order the lab. There is a special type of lab order called stat labs. Most people recognize the term stat from medical TV shows, meaning immediate, needs to get done now. And this can be done at any setting, even in office settings where there's a courier that picks up. When you request a stat lab, that means a courier will come and pick it up within the hour, and then it'll be pushed up to top priority once it reaches the lab. You can even get these semi-emergent labs from an outpatient setting, and it might save the patient from an ER visit. One special mention about labs is the emergence of direct-to-consumer lab offerings. A lot of patients really just want to know what's going on inside their bodies. And the reason I think this industry exists is because a lot of doctors don't feel like it's necessary. There are a couple principles that we learned during training. Number one, don't order tests for which you're not going to do anything about the result. Two is that don't just randomly order labs because it's a cost consideration. You're using up resources pointlessly. But a lot of patients do want some labs that, number one, aren't indicated, and number two, will generally not show anything, or the doctor doesn't want to have responsibility for the results if something does come out, and therefore direct to consumer. And this happens a lot actually in the urgent care setting. Over the 3 years that I've worked in the urgent care setting, there are patients every now and then that come in and say, hey, I want my vitamins checked, Or, hey, I talked to so and so who said that my symptoms are because of iron and I just want my iron checked. Don't diagnose me, don't do a proper workup. I just want my iron checked. These patients, I will actually write down the direct to consumer lab places where they can go and get their labs. The major lab companies like LabCorp and Quest actually do have a direct to consumer platform where they will sell the labs themselves and people can pick. And it's all marketed well, quote, men's health, women's health, whole body evaluation, or something like that. And it's really just super basic labs that they just package and make it look pretty. There's even a whole company called Labs on Demand where patients just go and click whatever they want, put it in a shopping cart, show up to the location and get their blood drawn. The interesting thing about this is that lab orders all require a doctor's prescription. Even on the front end, even though the patient is ordering whatever lab tests they want by themselves, on the back end, these companies actually have a doctor who either has signed standing orders or is going through at rapid pace and signing through all these labs that the patient has requested. There's a couple legal questions I don't have the answer to. One of them is responsibility of the labs. Earlier, I mentioned that we generally don't randomly order things because if they're, say, incidental findings that probably don't matter but stress the patient out, or if it's a patient we haven't met and we just order a lab, we're responsible for the values, or at least we're taught we're responsible for the values, like what happens next. And I've tried looking into this and I'm not sure what the answer is. If there's like a crazy lab value that really needs to be followed up, I think the way these lab companies get away with it is they say, hey, this is crazy, you should go see a specialist, or hey, this is super crazy, you should go to emergency room right now, and not really necessarily give a full explanation for what it means. But I guess it's like a form of triage where you can see normal and abnormal. And if you really want like an in-depth, real explanation from a real doctor, they just recommend you go see somebody and talk to somebody. The next type of order is imaging. The logistics of imaging is actually still pretty messy. There are differences between hospital systems versus independent practices. It's a little more clean inside a hospital system. When imaging is ordered, it usually goes to central scheduling, the same place that schedules office visits and everything else. They see the order, they call the patient schedules, and they go in. In independent practices, it's a little more disorganized, where the most common type still is an order sent either through EMR integration or an electronic fax or a manual fax to the imaging center. And then the patient, more often than not, will have to call the imaging center themselves after the order is in to schedule an appointment. Most images are scheduled, but there are certain types of imaging, like x-rays, that tend to be just walk-in. Once the patient gets the imaging study done, then it goes to a radiologist who reads and interprets and sends back their interpretation. Inside hospital systems, generally the primary care doctor can see both the image and the interpretation. And rarely, but sometimes, if there's a discrepancy, they can actually reach back out to the radiologist and ask questions. Private practice is a lot harder. There is software now with a lot of hospital systems where you can share the actual image itself, but for the most part, private practices only receive the impression or the results the radiologists read. And so it's a lot harder to actually see the image, and a lot more trust is placed on the radiologist reading the image. As of now, there's no direct to consumer imaging, but what's become semi-popular in the higher income classes that generally engage concierge are imaging studies that the rest of traditional medicine considers unnecessary. The most popular example right now is a full body MRI. A lot of concierge practices will order full body MRIs, which are generally low resolution MRIs that look up and down the whole body. And that's probably the closest thing to direct to consumer because it's something that people want, but they don't really need, and they'll pay out of pocket for it. One interesting imaging modality is the coronary artery calcium score. This is essentially a CT of the heart looking for calcium. And the calcium in the heart is used as a surrogate of plaque development, or in other words, it's used as a risk stratifier for impending heart disease. If there's a high calcium burden, that suggests there is a higher risk of developing a heart attack compared to people with low to no risk. Right now, there's no professional guideline that recommends this. However, major specialty organizations like the National Lipid Association have guidelines and recommendations for who they think should get the CAC scoring. And because there's no official bigger guideline for it or grade A recommendation, there's no insurance that covers it. And so the CAC almost looks like LASIK in that it's a purely free market imaging study. And in my area, because I like doing lipidology and I've ordered this for plenty of patients, the imaging centers actually will run specials on this particular test. For example, for National Heart Awareness Month, they'll have discounts on this and they'll actively promote this study because it's about as close to a direct to consumer study as there can be. A lot of the free market advocates will talk about how LASIX, as it was a pure cash procedure, is now a lot cheaper than most medical procedures because insurance didn't cover it, as an argument for how market forces actually drive costs down, whereas using insurance drives costs up because of the lack of transparency. The CAC is a non-insurance covered study, and the price is fairly reasonable and fairly standard actually across regions, and imaging centers will run specials on it because of the price transparency. Now, labs and imaging, they have a couple things in common. One is due to new information transparency regulation, results are visible immediately. So when a lab results at the lab company, or when the radiologist has submitted their final reading, the patient automatically gets a notification. The notification ends up showing up at the same time for the patient as the doctor. But of course, more often than not, the patient's going to see it first because the doctor has dozens of other lab results flowing in at the same time. And that's usually in between patients, whereas the patient just has their own set of labs. And when they get the email or text, they're probably going to want to check it immediately. There is some discussion and debate about the pros and cons of this legislation because the pros are, yeah, the patient can now see their labs and it's good to be transparent and it is their data after all. But the cons are the patients will now start harassing doctors early about lab results, especially the more anxious patients who see the red. When we get lab results back, anything that's outside of normal interval will have an exclamation mark or it'll show up in red or bold just to show us it's abnormal and to have us pay attention to it. But most of the time, it's not something that is actionable or it's something that is outside the range, but not in a meaningful way. And so if a doctor saw it first, they could then write out a thoughtful response so that the patient can see the interpretation at the same time they see the result and not panic. But now, when the patient just sees the exclamation mark, the bold, the red, they sit there and they panic until the doctor is able to get to it. There's some back and forth about whether or not this is good, but for now, it's considered a net positive. The other thing is pricing. There's really three ways to price out labs and imaging. It's either cash pay, so self pay, the hospitals, imaging centers just determine what the payment is, usually at the point of service. Client billing, which is where practices have negotiated special rates with a certain imaging center with the implicit promise to send most, if not all, their patients over to that center for discounted client bill rates, or the traditional model, which is just insurance. That's something that the clinician doesn't control, but is negotiated ahead of time with the patient's insurance carrier. Up to this point, it's been pretty hard to get the true price of these labs. This is something that direct primary care practices have taken advantage of because direct primary care practices, usually through group purchasing organizations, will have much lower lab prices and they'll post them publicly or mark them up and post them publicly, or at least from a marketing standpoint, say, hey, our lab prices are significantly lower than if you use your insurance. Because for the most part, direct primary care practice don't mark up their labs and they actually care about how much their orders cost their patients. But recently, with the hospital price transparency law and the health plan price transparency law, it's becoming a lot easier for the consumer and the doctor to look up what things cost, either from a cash pay standpoint or from the insurance standpoint. And companies like Turquoise are making it much easier to just log on and see what true prices are. When these laws first came out, which is recently in the last couple of years, it was still very hard to find it because number one, the health plans and the hospitals were fairly non-compliant with the law. And two, the law said you had to present these prices in a quote machine readable format, which usually meant this like massive document with a lot of letters and numbers and was super confusing. And there were other ways people did it where you had to call in to get the rates, and it was just varying levels of compliance and making it as obscure as possible, despite it being a transparency law. But as time progresses, there's a lot more compliance. And again, these companies are making these opaque methods of transparency a little more clear. The final section is DME, or durable medical equipment. That's just fancy terminology for supplies. Now, there's two main categories: mandatory prescription DME and optional prescription DME. Mandatory DME are supplies that require a prescription that you can't just buy on, say, Amazon. And this exists because of legal regulations. For example, a CPAP machine. The CPAP machine is continuous positive airway pressure machine used most commonly for sleep apnea. It pushes air into your upper airway, keeping the airway open so that you're not choking on yourself while you sleep. If you Google CPAP, there are prices that you can find, but when you try to buy them, it still requires a doctor prescription. One interesting direct-to-consumer mandatory prescription supply is CGM, or continuous glucose monitor. These things have become very popular recently because it's pretty helpful in terms of weight loss, and people find it fun to see how different foods affect their bodies. Due to the popularity and relative cheapness of them, it's about $70-ish for the cheaper one for a 2-week sensor. There are plenty of companies that are direct-to-consumer wellness apps or wellness services that include a CGM. And just like the direct-to-consumer labs, they also have a doctor in the background who will write the prescription and then send it to the customer as part of the program. Now, in terms of these mandatory prescription supplies, the logistics are pretty odd. There's a couple ways to order them. One is forms. So the companies will send forms. A common one is the Omnipod, which is an insulin pump for type 1 diabetics and some really out of control type 2 diabetics. The Omnipod will send a form that you can fill out, and it makes sure that the correct diagnosis is done and the correct criteria are met so that it's easy, so that there's not pushback from the insurance companies. Another one, more commonly perhaps, is the Cologuard, which is one of the options for colon cancer screening. It's the one that you may have seen commercials on with the box that waves at you. But Cologuard, to order Cologuard, they have order forms online, and you fill it out with the requested information and send it back to them. And that's how it's ordered. Generally, in larger hospital systems or traditional systems where there's staff, the nurses will fill it out. Some of the specialized forms, like on Omnipads or certain continuous glucose monitors, nurses that fill it out over and over will get pretty good at it. And the doctor will just give the form to the specific nurse, and then the nurse will pass it back to the doctor when it's filled out. They review it real quick and then sign it off. The other way to order DME is, of course, just like labs and imaging, through the electronic medical record. Generally, this is On the front end, the doctor side, it looks just like an order, a regular order, but on the back end, it's just as manual where the order gets routed to somebody at a call center, and then they contact the patient and let them know that the order is ready. In both the form and the EMR order, the patient then still has to go to a DME store. There are specific stores that sell this kind of prescription supply. Again, very manual process. Either they'll be given a paper list of where these places are, or the person on the phone will notify the patient of where they can go based on their insurance or based on hospital affiliation. But pretty manual process overall. And then there's the optional prescription supplies. Optional means that these are things that you can generally buy over the counter or on Amazon, but a lot of people will get the prescription for insurance purposes because their insurance will pay for it. One common example is any sort of musculoskeletal support, whether it be crutches or walking boot or a post-op shoe. These things you can find on Amazon, but people will use their insurance. But sometimes if you use insurance, it actually ends up being more expensive than if you just went on Amazon and bought it. In the urgent care setting, where a lot more acute injuries happen, some urgent cares will have these supplies on hand. And at that point, it's really only through prescription and through the insurance. But sometimes if they're out of the supply, retail pharmacies will sell these, usually not through insurance, it's over the counter. And then, of course, just regular retailers. One example of a medical supply that has moved into common retailers are compression stockings. So before, compression stockings were a prescription durable medical equipment, but now you go to Walmart or Target and they also sell compression stockings, sometimes even cheaper than any durable medical equipment store. One thing about orders from the primary care practice, this claim that some people in the health policy circle say is that even though only about 5% of healthcare dollars is spent on primary care doctors control about 80% of downstream spending because of the orders. On aggregate, when you think about the entire population and how many encounters there are with primary care and how many orders come from those encounters, intuitively, it's not hard to realize the magnitude of cost that this adds to the healthcare system. Now, I haven't found any papers or figures that support this claim, but based on intuition, it makes sense. Perhaps not as high as 80%, but primary care does have a pretty big effect on downstream costs. And this makes the second point a little more possibly concerning, but more important is that a lot of doctors don't know and potentially don't even care how much their orders cost. For the more conscientious doctors, they only order things that are necessary, and so they don't care about the cost because they feel like the benefit of getting the lab result or getting the benefit of the order far outweighs the financial cost to the patient. And for less conscientious doctors, they feel like there's so many variables. They have to know what insurance the patient is on, what imaging or lab centers that the insurance is contracted with, how much they've contracted with, and then they have to know this for all 30 patients that they see that day. It's too much to know. And because of that, there's some passive apathy and they just order what they think they need without second thought of what it might cost the patient. Perhaps with the price transparency laws, there might be some more awareness on the consumer side and therefore trickle up to the doctor side, or hopefully for the more conscientious doctors, the doctors will better understand what images, what labs, what supplies cost and be more conscientious there, or at least have more informed discussions with their patients on how much things cost and really help affect the healthcare system spending by having more informed conversations.
To summarize, the session covered logistics related to labs and imaging in primary care. We also share our insights about placing durable medical equipment orders. This concludes session 15.